I'm Dr. Allan Perel, and this is Conversations in Medicine. Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island, New York City, and entire tri-state community. Tonight's topic is cardiac arrhythmias, a very fancy word for irregular heartbeats or palpitations of the heart. We've talked about in the past all kinds of different heart conditions, but this is a very common one. How many of us have not felt palpitations? Cardiac disease is the #1 killer in the United States. We've all been affected by heart disease. And I have two wonderful experts in the field of heart disease who are going to join me here tonight. One is Dr. Nidal Isber, the Director of Clinical Electrophysiology at Richmond University Medical Center. Welcome. And the second is a close friend of mine, Dr. Antonio Caracta, who's been a cardiologist on Staten Island for many, many years, too many years for us both to recount, over 30 years. If you had to say, he's almost Dr. Cardiology. He's been involved with some of the major early research in cardiac arrhythmias. And it's my pleasure to have you both back here. Thank you.
Thank you for inviting me.
So we're going to talk about heart arrhythmias. And I'll actually ask Dr. Caracta first, be more of the clinical aspect of this. When someone comes into your office and says they have palpitations, or they feel they skipped a heartbeat, what do you ask them and what do you do?
Well, I tried to get a very good history, okay? And I tried to find out what is the age of that patient. Patient is, say, comes into you at age 30 and says, I have palpitation. Then I want him to describe the palpitation. Is it rapid? Oh no, it's just like, it's skipping a beat and I feel it in my throat, okay? Now, I know that's not palpitation, that's a skip beat or an extra beat. On the other hand, I ask the patient if the patient now has structural heart disease, say he's 70 years old and is complaining that his heart is beating irregularly or even regular, then I try to elicit from him, how did it start? And is it constant? So then when I take his pulse or do a physical examination and his heart rate is, say, 180, and
that's very high.
That's very high. So, and I suspect that he has a supraventricular tachycardia or an atrial arrhythmia because his blood pressure is still okay, his vital signs are all right. So then I then proceed to do an electrocardiogram in the office. And one of the most common things we see in this patient population with coronary heart disease, patients with hypertensive heart disease, and our valvular disease is atrial fibrillation. So now at that point in time, I have made the diagnosis of what his palpitations from. Now going back to the first patient, that patient I do a cardiogram and I see a ventricular premature beat. And I tell him, don't worry about it, it is a benign arrhythmia, okay? Especially if you don't have any structural heart disease, then what I'll do is I'll reassure him. On the other hand, this patient now has to be taken care of immediately.
Absolutely. So Dr. Isberg, in your experience, there are benign and more malignant arrhythmias. How do you evaluate someone? If someone comes to you, and I know you're one of the later steps where someone who does ablations and pacemakers and things to treat it, but as a cardiologist, what do you do early on? As Dr. Caracta said, getting a good history is very important.
Sure.
What do you do on your physical exam? What kind of tests do you do in order to determine what kind of arrhythmia and actually even before that, maybe tell us what you do about it in your exam. We'll talk about what the electrical structures of the heart is. Most of us don't really know. Many of my wonderful audience might not know that the heart really gets, all those beats go in sync because of electricity. That a lot of the body, and as a neurologist, we see so much of it, it's neurons that the nerve cells go and are electrically stimulated. So nobody would think we have electrical stimulation. We don't glow like an electric eel. But in a sense, maybe I'll start with that.
Sure. First, initially, I have to say I'm delighted to be sitting near Dr. Karakta, who's a real pioneer in electrophysiology.
Thank you.
Actually, he put the foundation with his group of electrophysiology and taught so many people in the world. So thank you for inviting me with him. Usually, we go through a lot of history, as Dr. Karakta said, and physical examination, and we collect data about the patient. Usually, as he said, some PVCs or extra bead in the atria or the ventricle might not have any risk marker, but there's different risk markers even if there is any PVC or APCs. The risk markers would be the function of the heart. This is the main determinant of the risk. If the heart function, the muscle, is good without prior heart attack, without heart failure, meaning probably I would say it is benign arrhythmia. Usually all SVT are benign, usually.
That's supraventricular
arrhythmia. In the absence of other factors, usually benign. It can give you a lot of symptoms, it can lead even to passing out, but usually it is benign. Only the arrhythmia coming from the ventricle, then those arrhythmia are, might be malignant. However, the main determinant of being malignant is the function of the muscle. Of course, there's a specific situation in which the arrhythmia coming from the upper chamber, from the atria, could be malignant, like the presence of a bypass tract that was low bypass tract that, for example, atrial fibrillation, you could conduct very fast through the bypass tract, leading to extremely fast heartbeat in the ventricle, leading to cardiac arrest.
So let me go through a little bit, because again, complicated even for a neurologist to understand. And we consider ourselves somewhat knowledgeable about electrical currents, as I said before. So we have a model. And when you use the word supraventricular, you mean above the ventricle.
Right.
So maybe if you could show what's above the ventricle, what's below the ventricle, give us a little idea
Sure.
of what's in the heart.
Initially, the upper chamber and lower chamber actually isolated from each other electrically. There's a conduction system that conduct from the upper chamber to the lower chamber. So what you see here, the upper chamber connected to the lower chamber. However,
we're going to have to turn it around a little bit so they can see it.
Okay, sure. This is the upper chambers. This is the lower chamber. Anything related to the upper chamber, we said, might be actually benign. Not all, but the majority. The bottom is a ventricle, which is related to, associated with high risk.
So we have different chambers and different kinds of things that are happening. And Tony, maybe you could help us a little bit. Tell me about the conduction. Where does it start? And I know you do a lot of work with EKG. I see your name on so many of the EKGs at the hospital. Let's start a little bit. When you talk about conduction, there's different things that go there. And when you use the word conduction, it's almost like they're actual fascicles or actually connections that go. So tell us a little bit. Maybe you could help us about what kind of nodes they are and all the words that people hear.
Actually, the human heart has its own pacemaker, and it's called the sinoatrial node, and it's located right here in the right atrium. And then there are conduction pathway that goes to the in-between here, and you can go see it near the AV junction, they call it, between the atrium and the ventricle, and that's called the AV node. And from the AV node is a little bundle, and it's called the bundle of His, and then it divides into three portions. One goes to the right ventricle, this one you can see, and the other two has two divisions. One is the anterior division, and one is the inferior posterior division. And so this is like an electrical wire going to the heart, and when the pacemaker here automatically sends a signal, and it's automatic. You can't tell your heart to stop. It will automatically give you a signal, and it will go to the ventricle. The electrical event then precedes the ventricular contraction of the muscle of the heart.
So
you-
the goal is what? The goal is for the blood to go into the big muscle, the ventricle, and pump.
Yes.
And you want it in sync.
Yes.
Because if there's not a lot of blood in there and it pumps, you're not going to
Right.
get as efficient a process.
Correct.
So that's why you want this to be in absolute sync.
Right. That's why the atrial contribution to the cardiac output is very important. In people with structural heart disease, if you lose that 10% of your cardiac output, you can be symptomatic.
Which means
Which means you will have shortness of breath, you can have fluid in your lung, and you'll be having problems with edema and the whole spectrum of congestive heart failure.
Dr. Esper, we watch TV a lot and we hear about people who've, sad to say, have had sudden death syndromes. And on television they'll say that they had a massive heart attack. But someone who's involved in electrical heart matters, what usually happens to someone who has sudden death?
Sudden death is caused by myocardial infarction or caused by prior myocardial infarction or caused by primary electrical problem that the patient might inherit. But the most common cause of death is actually acute heart attack. It could be small, it could be large. However, 30% of the people who get heart attack, they don't even make it to the hospital. They die in the way, maybe in the hospital, or if they are delayed. During the first an hour, 30% of people will die. So the best things, if somebody has chest pain, to immediately go to the hospital and not to delay, because he could arrive to the emergency room and he could have a lethal arrhythmia because of the heart attack.
So you just define lethal, you could die from lethal.
Lethal.
Arrhythmia means that your heart beat, you won't be in sync, and say your ventricle will not pump properly. So ventricular fibrillation, which means that, or asystole, not moving, but it just doesn't move efficiently.
Actually, it fibrillates, meaning the heart rate become extremely fast. Like from a normal heart rate of 60, 70, it becomes suddenly 300 beat per minute, which lead to lack of contraction. Very little blood is being ejected from the ventricle, or even none. So sudden cardiac death occur and only could be saved by a defibrillator or a shock delivered, either in the emergency room or by paramedics and so on.
And so tell us why you talked about that, the concept of AEDs. I was chairman of the board of the Staten Island Heart Society, American Heart Society, for a number of years. Tell us a little bit about AEDs. It was a major effort, even with our borough president, Jimmy Otto, to get these devices, these automated electronic defibrillators, external defibrillators, out into the population. So in libraries. And interesting enough, what shocks me is I actually see them there in the lobby of the hospital. Even though there's an emergency room, they're still in the lobby. Baseball fields where a child could be hit in the chest. So tell us from your point of view, what's the value and how quickly and are people okay in doing it?
Just a review of this subject. Strategies has put to combat sudden cardiac death. One of the strategies everybody knows is paramedics, which is effective but not very effective for sudden cardiac death.
CPR in a sense?
CPR and advanced life cardiac support, followed by defibrillator. So the automatic defibrillator or semi-automatic defibrillator distributed everywhere was another strategy that we hoped it's going to make impact on sudden cardiac death. But there's impedance to it because people don't know if somebody has cardiac arrest at home or in the street or in the supermarket. There is no knowledge where is the closest defibrillator to be used. So I think we reach a point that we hope that it's going to make big impact on the prevention of sudden cardiac death, but it did not progress to a satisfactory level. I mean, it's true it's present in the airport or in a school, but how to get it? How fast? What's the knowledge about people who are taking care of somebody who just had cardiac arrest to get it or to think about it? So we need more education and more strategies to have it any impact on.
I'm going to go back to you,
on
Tony.
outcome.
We're going to go back to some more other the arrhythmias that people in our community know. So atrial fibrillation. It seems like everybody's heard about it. Somebody knows someone who has atrial fibrillation. There's always the question about what do you do about it. So when you mentioned you do an EKG and someone
Right.
has palpitations, heart rate is a little high or very high, and you diagnose this atrial fibrillation on an EKG. And that's how you can do it, because the atrium or the top of the heart, one of the upper chambers, doesn't beat in sync.
Correct.
So when you make that diagnosis, what do you tell the patient? What do they have to do, and what could happen to them?
Well, it's interesting because when I, in practice actually, most of these patients can have no symptoms at all, especially if their fibrillation is controlled and the rate is between 60 to 100. Seldom do you see them complain that they have any symptoms unless they have structural heart disease like angina and heart failure. On the other hand, most of the sudden atrial fibrillation that we see are very fast. Okay, as like you say, the atrium is beating, say, 600 beats per minute, and is going to the ventricle, and the AV node stops it, and the ventricular response is, say, 180. And the telltale diagnosis that you see on the EKG is no P waves. P waves appear when there's a normal sinus rhythm from this normal pacemaker of the heart. And then we call it irregular, and it's irregularly irregular. Okay? Once you make that diagnosis, you have that. Now, the treatment for that, as Dr. Isber will tell us later, is that you try to maintain a regular rhythm. And you put that patient to the emergency room. You try to slow down the heart rate. And most of the time, with medication that we give to slow down the rate, they can convert to a regular rhythm. Okay? But the immediate thing that you have to do is you assess the patient carefully. If the patient is having low blood pressure with that rate, if that patient is almost passing out, if that patient is complaining of unrelenting chest discomfort, that's an emergency in atrial fibrillation. And the treatment for that will be DC cardioversion. You shock the patient back to normal rhythm.
So Dr. Isber is going to give us some details about what you do as an electrophysiologist at a major hospital in New York City. And tell us what I see you have some wires and pacers and things like that, and people have heard about cardiac ablation and all kinds of different words. So maybe enlighten us. Tell us a little bit what to do with someone with atrial fibrillation.
First, we have to take a good history and see how long the patient has been in atrial fibrillation. Has been the patient anticoagulated?
Which means blood thinners,
blood
very strong
thinner.
blood thinners.
Blood thinner will prevent the clot. The presence of AFib predisposed for clot formation, which might lead to stroke, dislodgement of the clot going to the stroke or to the other part of the body. So we need to know definitely before cardioverting a patient that this patient has been on blood thinner long enough that it is safe to do cardioversion.
What is cardioversion?
Cardioversion is an electrical shock that we apply to the heart during a patient who is sedated to restore the normal rhythm. Which
Is that done externally or internally?
No, external.
So you don't have to do, it's not surgery?
No, it's just outpatient, very simple procedure, just a press of a button and by the defibrillator, and that's it.
What percentage of patients get better with that?
The vast majority of patients who have short duration of atrial fibrillation will convert successfully to sinus rhythm.
Which is the normal rhythm.
To the normal rhythm. People who have long duration atrial fibrillation, it is difficult sometimes to maintain normal rhythm after cardioversion. And here the idea that usually we try to minimize the duration that the patient is in atrial fibrillation. There's something we call it AFib begets AFib. The more he is in AFib, the more there is structural problem in the atria, changes in the atrial muscle. It becomes difficult. So, but usually if it's 1 month, 2 months, it's okay. But I have seen some cases like like a year or 2 or 3, it become a little bit more difficult. But with the help of antiarrhythmic medication, After cardioversion, we may maintain the vast majority of the patient with into sinus rhythm.
So tell me about cardiac ablation, where catheters are used. Tell us a little bit about that.
Ablation is burning or cauterizing part of the atrial or the ventricular tissue that's responsible for specific arrhythmias. The invention of radiofrequency energy in the early 90s revolutionized the field of electrophysiology, and it started to become interventional electrophysiology. The catheter is usually inserted in the vein or in the artery, goes to a specific part of the heart that's responsible for the arrhythmia. On the tip of the catheter, as you see, 2 millimeter in diameter, 4 millimeter in length, which is deliver the radio frequency. The ablation catheter is connected to a generator, and we go to the heart and we manipulate the catheter to the area that's responsible, and we make just cauterizing the area. And each disease has different technique. But nowadays, arrhythmia are cured, the vast majority of arrhythmia cured by radiofrequency energy.
So you break the circuit. In other words, if you have an short circuit in a sense, and you break it by this burning of the tissue.
If there's any extra pathway, you burn that extra pathway. If there's any a part of, we call it critical part of the circuit, you ablate that critical part of the circuit, and so on.
So if someone has atrial fibrillation in their home and they're seeing their internist, and whatever age they are, they're still running around, they're playing golf, they're doing things. Could most of those patients, if they went to an electrophysiologist or through their cardiologist, eventually go back to a sinus rhythm?
The vast majority they do with the help, some of them, with anti-arrhythmic. Anti-arrhythmic is very strong medication that can change the electrophysiological property of the atria or the ventricle, and make it difficult for the arrhythmia to initiate. So if somebody has atrial fibrillation, we see what's the frequency, is it bothersome to the patient? If they have only one episode, we don't expose them to anti-arrhythmic because it has a risk also. We watch them. If they have more frequent episode of AFib, then we put them on anti-arrhythmic medication, in addition to cardioversion every time that they have. Then if anti-arrhythmic, even a combination of anti-arrhythmic has failed finally to maintain normal rhythm and quality of life become not good for the patient, then we do ablation.
We've come a long way.
Yes.
Tell me a little bit about anticoagulation. Okay. Everyone is afraid of Coumadin. There are a lot of these new agents called NOACs, novel oral anticoagulants, different ones that are out there. What's your opinion about them? When do we have to use them with these irregular heart rates?
Okay, well, the mainstay of treatment for atrial fibrillation is anticoagulation, a blood thinner. You know there is an increased risk of thromboembolic phenomenon, meaning a clot from the left atrium or the left side of the heart can go into your brain and produce a massive stroke, or to the legs, or to different organs of your body. Okay,
and so cut off blood supply.
And cut off blood supply, right. And there is death of the tissue. So I'd like to, if the patient, for example, like Dr. Isber mentioned, came in, but most of these patients may not have any symptoms, and you see them in the office, they're in atrial fibrillation. And these are the patients you have to anticoagulate. Now the choice about 20 years ago is Coumadin, because there was nothing available at that time. And there were several studies that shows that if Coumadin, if you compare with the placebo, prevents stroke and systemic embolus about 62%. So that's the gold standard. Now, nowadays we have, but the problem with Coumadin is that this patient has to be treated in a therapeutic range between 2 to 3. It's called an INR. And that's why we have a lot of these Coumadin clinics.
Getting blood work all the time.
Getting blood work all the time. Now, they may be able to control them every 2 weeks, every week, every 4 weeks, but they have to be in that therapeutic range. Now, the problem is we can only do that about 60% of the time. Okay? So therefore, there's a need to take care of the 40%. Those 40% may be anticoagulated. They have a chance of bleeding.
So
or
their blood is too thin.
Too thin, or they're too thick, and they're not in the therapeutic range, and they have the risk of thrombosis, clot, and stroke. So now, about 6-7 years ago, they come out what you said, NOACs, new oral anticoagulant, which there are about 4 now that is available. Okay, and one is a direct thrombin inhibitor, and that's.
I'm not going to go into the details of that. That's
Okay.
very complicated,
Yeah.
but they seem like they're advances on Coumadin.
Yes, there's advances in Coumadin. It is not inferior to Coumadin, but what is interesting that we found is that if you look at the safety profile of this drug, okay, it's as safe as Coumadin, and it is better because it prevents fatal bleeding and also intracranial hemorrhage.
So I'm going to interrupt you because we're ending in a few moments. Let me ask you a question, Dr. Isber. A lot of my patients with stroke, we call them cryptogenic, or we don't know what caused the stroke.
Sure.
Atrial fibrillation, as Dr. Karaktan yourself was mentioning, is a common cause of it. Sometimes people don't even know they have atrial fibrillation, and they have this little clots in the left atrium, and they shoot down into the ventricle and then into the carotid artery circulation and cause a stroke. If I can't find a reason for someone to have had a stroke, what do you do when I send them to you? What do you do to help me find the cause?
Yeah. One of the major cause of cryptogenic stroke is atrial fibrillation. We call it silent atrial fibrillation. As Dr. Karakta said, AFib, some people don't have any symptoms. So we go ahead and we look for AFib fibrillation. Long term would be better than short term. In short term, we can give them a Holter monitor, but for a day, or we can use other diagnostic testing. But nowadays, there's a loop monitor, a small loop monitor that can be inserted, can be actually injected underneath the skin. This has a capacity to monitor the heart for 3 years duration, and it can give us information wirelessly to our computer, and it will tell us if there's patient has atrial fibrillation.
And you can live normally with that in you.
Exactly.
Why you could have MRIs.
Exactly.
You could have X-rays. You could go through.
Exactly.
You can go through TSA at the airport.
Oh, definitely.
Okay.
But I just want to make one point that the presence of atrial fibrillation will dramatically change the strategy of treatment from aspirin, as we know, for stroke, to anticoagulation with Coumadin and the new anticoagulant.
And I think the number is almost 25 to 33% of patients will find something on one of those loops that you keep in for a few months.
And will change the
strategy. And will change our therapy
Sure.
and hopefully reduce the risk of stroke in the future. Although cardiac disease is the #1 killer, stroke is the #1 cause of disability in the world.
One of the things that I forgot to mention is that when you see the patient in the office, for those patients, you have to risk stratify them by doing what is called the CHAD score.
We're coming up to a few seconds left, but a CHAD score is just a score to see who's at increased risk for this.
Yes.
Whether if you're very young and you have it, sometimes we don't treat aggressively. If you're much older with heart disease, we do. I want to say thank you. We're almost finished now tonight, and you've told us so much about some new things and things that have scared us all for many years. Atrial fibrillation, ventricular arrhythmias, sudden cardiac death. And we can't treat them all right now. We have pacemakers and different devices. We've come a long way. I want to thank you both for everything that you've done for me and on Staten Island. It's a pleasure to have you as guests, and thank you again.
Thank you.
Thank you.